good afternoon and welcome to MedTech Crossroads. Today is episode 104. I think that makes just about 2 years worth of episodes. Actually, been a little bit longer than that, so we're excited to have you with us today. Today, Friday, May 6th, into the month of May. And with the month of May, a new series. We've talked a lot about how important it is to get the perspective of your users. And if your users are clinicians, we need the clinician's perspective. So I'm thankful in concert with ArborHive, and I'll be joined in just a few minutes by Dr. Niki Kennedy, who runs that amazing effort. We will be talking today to a clinician, and for the rest of the month of May, to clinicians about their perspectives. What are problems that they have to solve? What sorts of things do they run into on a daily basis? Just because some of us who might be engineers think we have a problem that's cool to solve, do we really understand what they're up against? It's important to understand. Do we really understand what they're up against? It's important to understand that, and that's what we'll be doing this month in partnership with ArborHive. Just a couple announcements, though. Midwest Growth Capital Symposium is back as a virtual event. We'll be part of that, and that's happening on May 17th and 18th, coming up really quick. So be sure and get connected. If you scan that 2D barcode on the screen there, you can get redirected to the Midwest Growth Capital Symposium website. And don't forget, in person, the Michigan Medical Device Summit, rearing back on September 20th. This has been a great event in years past, has often drawn notable figures from FDA to the summit. And we're looking forward to that, sponsored by Mish Bio on September 20th in Kalamazoo. And that brings us to the main event, the clinician's perspective in partnership with ArborHive. May 6th, that's today. May 13th, May 27th. There's a gap in there. We'll talk about that later. And June 3rd, we've actually extended this series for an extra week. So we're going to hear from the healthcare perspective for 4 weeks here, which is going to be just wonderful. And joining me today is the founder, as well as our first presenter, Dr. Niki Kennedy.
Hi,
welcome.
Chief.
How's it going?
It's good to see you in person.
In person, in the flesh. I feel like I have to shake your hand.
Absolutely,
because here we
friend.
are. We're here together. It's great. Before we get into your background, which is kind of amazing, I think the only thing you don't have is a law degree.
I'm good with not having that.
That's the best way to say it.
I have people for that.
Only thing she doesn't have is a law degree. But vascular surgeon by training, MBA, yes. Among other things. Before we go into that, I want you to tell us about ArborHive, why you started it, and why it's important.
So, Gene, I know you and I have chatted before, and some of your audience might remember as well, but I started as a biomedical engineer. I started out as a college student working for a dental device company, so I learned about FDA audits, I learned about packaging, sterilization, quality assurance. It was exciting, to say the least. And I loved it, and that's what I wanted to do, but it's hard to solve problems when you don't know what the problems are. So I spent a few years languishing in grad school saying, I just don't know what doctors want. And I decided it was just time to go be a doctor. Not recommended for everyone. Don't do this at home, kids. But for me, it was life-changing. So I spent about 20 years doing what I do, ended up as a vascular surgeon. But for me, I still felt that drive, that passion for innovation. And probably about 2016, I had a chance to work with University of Michigan's Fast Forward Medical Innovation Program. They had a program down at TechTown, actually, talking about their fast-paced course, which was absolutely everything I had been craving all these years and never quite knew how to achieve. Led to me going back to University of Michigan to get the MBA, had a chance to meet a lot of people at the Midwest Growth Capital Symposium, and eventually I met people like yourself. And I realized there was a real need for docs to get involved early in this process, because so many times we'll be in the OR and we'll say, wow, why did they make this handle like this? Why did they design this device the way they did? They should have done it in a different way. And I realized maybe it'd be better if doctors talk to designers earlier in that process. So I started helping out a few people here and there and realized maybe there's something to this, and that's where ArborHive was born.
What I love about that is it's so near and dear to our hearts, because communication of things that you know in your domain, and you know other people need to understand it. It's just that rings so true to me, and so I think that's why we've hit it off and had the friendship and the colleagueship. Can you say that?
We're bros, man.
There you go. There you go. So tell us a little bit about this series that we're going to do. So this whole idea of getting doctors involved, and it, you know, as you and I've talked more and more, I realize this is a two-way street, right? You know a lot of doctors, you have a wide network all across, and I've come to you before and said, hey, Niki, who could we talk to that's kind of in this domain or this domain? But you're also interested in connecting with, tell us, I mean, startups and others.
Yeah, absolutely. So doctors need something to do. We have short attention spans and we get distracted by shiny objects. So what docs continually come to me to ask is, what kind of companies need my help? So for me, it's great to know people like yourself and like some of my other colleagues in the design side as well as in the commercialization side who can come up with different projects, different startup ideas, who need docs' input on this. Without that extra piece of it, it's just a bunch of docs sitting around, and we call that grand rounds, which we do all the time anyways. So we really need that commercialization, that innovation input. So my goal with ArborHive and connecting with people like you on your show today is to hopefully find some people who maybe have some ideas, maybe just want to pick a doc's brain because they're trying to come up with something. And more importantly, docs have problems, and we are not equipped to solve them. Even though I have an engineering background, do not ask me to do any CAD work for you these days. It would just be ugly.
It's been a few too many years under the bridge there.
Oh boy. So I think that it very much is a collaboration. We want to break down any silos. My running joke is, don't worry about throwing the box out, just forget about the box completely. There's no box. We want to make sure we have people from all areas of innovation and development to collaborate and have that conversation so that something good can come from it. And that can be a lot of different things. It could be a product, it could be a software, it could be a workflow process. And we try to keep things open.
Okay, conversation's got to happen so that you know what could come next.
Absolutely.
I think a lot of times people don't understand what an important role doctors and clinicians play in the development process. Because so many times you'll have somebody who invents something and says, this is great. And sometimes it's not a clinician to start with, which can be dangerous, good but dangerous. And other times it is a clinician, and they're convinced that this is the right solution, but no one else is. And that can be very challenging for them. One thing that we've found that I think it's a very fruitful area, and you and I have talked about this before, a lot of our clients are surprised to find out that when they go to FDA, first of all, it's box checking. Did you do this? Did you do this? Did you do this? Did you do this process right, et cetera? But once you're past that, you're into this world of clinical argument. And the number of times that we've had to bring a clinician to the table to tell FDA, I know y'all are worried about that, but let me tell you how it actually happens in practice, has been staggering. It's almost every single time that clinical voice has to be there. So I just think there's so many neat places where people don't recognize how useful it would be to talk to a doctor, to talk to a clinician in their domain that they're working in. So I think that's really cool. And we're going to hear from 3 doctors this series, as well as hospital staff that's responsible for
an administrator, actually, of a large local area hospital, which I think is really exciting.
That's going to be really fun.
That is very underappreciated area, because people always say, oh, healthcare providers, you guys are, you know, the backbone of this. But if it weren't for our hospital administrators, our doors would not stay open. I've worked in the quality area for a long time. We once at our hospital had CMS, DNV, and the Joint Commission all come through within 6 months for audit reasons. It turned out okay, but let me tell you, it's not because the docs were necessarily working hard. It's because we had amazing administrators who helped us make sure that we were meeting all those metrics, that we had everything documented. It's not a small task. And with COVID, supply chain issues, staffing issues, this remains an ongoing problem.
Well, and it's I think something that the startups in the community have realized over time is it's not enough to just convince a doctor that they need this thing. You have to convince the hospital system that this is important.
It's really more critical. I've had a lot of startups come to me and say, this is going to revolutionize everything in the hospital. And I say, but the hospital's already invested its CapEx into this older solution. What makes you think they're going to want to switch?
Yeah, they don't need it right now. They've got a solution that works. It may not be perfect, but there you go.
Yeah, but it's paid for.
And there it is. Well, that's the intro, but today you're on deck, Niki. So Dr. Kennedy is our guest today. And I think before and you've given an intro to yourself, but like we said, about the only thing you don't have is a law degree, and that's just a shorthand way of saying
I will
you've
say
done
this.
it all.
The more letters you have after your name, the more you realize you don't know in this world.
That's what sort of drives you to the next thing, asking those questions. I do think it's interesting, though, because when we walked in here into the studio, we were talking about like broadcast technology, and you said that was one of your early desires was to be a broadcast tech.
I went into engineering because I wanted to build an effects rack for my guitar, which I still have yet to do. It's actually still on my bucket list. So if this doctor thing doesn't work out, Rockstar is the backup.
There you go. It was a Brian May, I think, was the...
PhD in astrophysics of all things.
PhD in astrophysics. There you go.
And I think the guitar player from Boston actually was an IEEE member.
Wow.
Yes.
No kidding.
Blanking on his name. Peterson, I think the last name. Tom.
Okay. Someone's going to chime in there. They're going to raise their hand and they're going to remind us.
Great band.
So, but tell us how you got to where you are. You gave us a little bit of that background. Walk us just through the progression that took you to where you are today.
Well, so I will say my dad was a prosthodontist, still is. He's retired now. He had worked on a dental implant device, and he had gotten a patent on it, and he set up a company. Somehow I missed this when I was younger and in high school, but when I was in college and an engineering student, I was voluntold that I was helping him. Because at that time in the 90s, the FDA was a little more adversarial than they are these days. And they were knocking on his door all the time. So he had gotten himself an old copy of the Duran's Quality Control Handbook, and he was trying to figure it out. He's a very smart guy, but he's a dentist and really didn't have any training in innovation or business commercialization or regulatory affairs. So he needed some help with his quality control process. The parts he was getting weren't really in spec because he was ordering from a company in California. It was not anything you could control here in the state of Michigan. So I started writing a script in Lotus Notes.
Wow.
With a little digital caliper, and I would actually do the QA on all of his parts. And then we had to come up with a documentation process, and then we had to come up with a packaging and sterilization process. We had to document that, and then he had to talk to the IP attorney, and he just started dragging me along on all of it. Wow. And that truly is how I got my start.
Wow, that's amazing. I don't know if I knew that detail. So many of us got our start, on our first job or something like that, but you were doing that.
It was some late nights. We'd be there till 11:30, midnight, trying to get the documentation because we knew that the FDA guy was coming the next morning. So
wow.
Yeah, it was a little seat of our pants on that one.
This is before you went to engineering school.
Well, actually, no, I was a bachelor's at the time. So I was at Lawrence Tech doing my electrical engineering degree.
Wow.
And I was thinking about did I want to do biomedical engineering? Maybe I wasn't sure, but I had a lot of friends from high school who, instead of going on to engineering school, went to Wayne State for pre-med and eventually got into the medical school there. And as I was talking to them about what they were doing on call, I would be studying for my quantum mechanics test, and they would be sitting there in a call room waiting to help with some emergency hysterectomy. I realized that was pretty cool, and I kind of liked that a little bit more than what I was doing. So I decided not to pursue PhD pathway. I took the biomedical engineering master's and just ran and applied to medical school and ended up somehow again as a surgeon.
Wow.
I call it the ultimate engineering gig. So.
Why do you call it that?
If you like to problem solve, which I love problem solving, I'm not allowed to have Tetris or any kind of, I can't do Sudoku because I will just get so lost in it. Even jigsaw puzzles, I've had to ban jigsaw puzzles from my house. But if you love solving problems, patients have problems, and this is a very technical way to do it. Actually, one of the reasons I went into vascular surgery is because there is so much technology associated with it, not just with the imaging, but also with the wires and all of the tools that we use. It's a lot of fine stitching and a lot of using the magnifying loops, which is great when you're young. As you get older, the presbyopia kicks in, and the neck problems kick in. It's
I was in microfluidics. I remember gluing all those little channels together. Yeah.
Yeah, it does take its toll. But at that time, I said, this is great. I can go in and I can fix a person, just like an engineer can fix the machine. So.
That's so cool, and it motivated you to get into that. It strikes me as there are similarities in these areas where people love to problem solve in the engineering world, electrical engineering degree, in the medical world. But oftentimes, your love of solving the problem, other things get in the way of that. There's other factors. The engineer doesn't get to solve fun problems every single day. Sometimes it's a lot of paperwork interspersed between that, and the same is true for doctors as well. We're going to talk today about what some of those challenges are, what some of the things that docs actually run into. And as you and I talked, even some of it, as much as I've been in a parallel industry for years, and there's a lot that we do understand. There's a lot that I didn't. There's a lot of places
Sure.
where, I've spent time as a parent across the bed from
Very much
from
so
a
for you.
doctor. Yeah, our son's 1 year. You were on the show about back when he was born about a year ago, and
Pitch
so
party.
yeah, that's right. We're doing the pitch party together.
Yeah.
Niki, one of our judges, and so, but even sitting across that bed from doctors, there's just things you don't empathize with that they're going through, and that's kind of what we're here to do today and throughout this series, to really hear from the doctors to say, what is it that you experience on a day-to-day basis? And as you and I were talking, I think we both agreed the best way to do that is to kind of walk through a hybrid day.
Yeah.
And you're going to talk to us from the perspective of being inpatient, parts of your life at various points, this hybrid day of a doctor.
And again, being a surgeon, I have that bias of a surgeon,
Yeah,
where
okay.
our days do change quite a bit. I know some of your future guests from ArborHive are going to be coming up, and they'll talk a little bit more about their perspective, but I think I'm the only surgeon that you're going to be speaking with. So yeah, usually, and again, it can vary from day to day, but usually the day consists of figuring out what happened the night before. So there's a sign-out process with your team. You want to see what's on deck for the current day, either in your clinic or on your inpatient admission side, or with your OR schedule, or if you're doing an outpatient procedural, like I do a lot of varicose vein work, and I used to do that in my clinic when I was practicing with my old health system. And sometimes you're transitioning very fluidly in between all of those different arenas, sometimes unexpectedly, all within the same hour.
And of course, we think of surgeons, we think, well, they get cut on people, right? But that's not the majority of your work, even, because
No.
you're scheduling these things, you're talking to people, you're making treatment decisions and such like that. I would imagine that a lot of what you're doing looks like any other business communication at some level. You're emailing people, you're texting people. And this is going to be a recurring feature, I think, in our discussion, Niki, but HIPAA.
Yes.
You can't always just pull out your phone and
No.
say what, the audience or I would say to somebody. Now, in an industry like ours, where we're dealing with confidentiality, there are issues that are very much like that. We can't just shove anything anywhere. But you're under some pretty tight constraints. Let's make sure we understand the overarching, what's going through your mind when it comes to communication that's not just one-on-one, face-to-face.
And having worked in an NDA confidentiality arrangement, I get that. I think we all get that. But HIPAA is a whole other level. And it's not something I think everyone necessarily appreciates. I think everyone is aware of HIPAA. I don't want that's my privacy. I don't want that out there in the world. But when you actually think about how hard it is for your clinical team to talk about you and share information and ideas and plans without ever revealing your personal private information, especially to our internet connected world, it gets really complicated very quickly. Even, I just said, you're going to start out with your sign out. So you want to know what happened overnight to your patients. You want to see what's coming up for your day. Well, if I wanted to call my resident or my nurse practitioner who is taking care of the patients overnight or is taking on the patient load for the morning, I can't just pull up my cell phone and say, how's Mr. Smith doing? Because that's a HIPAA violation. I can't send it over a traditional unencrypted text. I can't sit there and, I can call them, but I have to be a little careful about the setting. I can't be in a crowded elevator and just start talking about somebody's private information and their lab values where everyone can hear.
Yeah.
I can't I can't ask them to send me a picture of what that chest x-ray looked like so I can see it, or a picture of that wound with any kind of identifying factors there. It can get a little dicey sometimes. And there are some pretty stiff penalties put out by CMS. They don't usually enforce it, but my understanding is it's about a $50,000 fine per infraction.
My goodness.
So the health system I was working for last year came up with a good solution. They actually found a technology that they purchased a license for. Of course, somebody else had invented it. I think it's actually a couple of physicians out of the Cincinnati area. But that was an app that we all had to have that had encrypted texting. It also had some very nice phone directory features, so you know who was actually covering that patient at the time. And you could send pictures and video. But it had its limitations. For instance, if that initial call tree wasn't set up correctly, maybe you couldn't figure out who was actually on call, and it was going to the wrong person. I know that we were not able to configure the alerts. It was just a limitation of the software. So as soon as I would put my gown and gloves on to do a sterile procedure when I couldn't touch anything, somebody would text me something like, okay, or thank you, or some little thing from a previous conversation, and my phone would start going off like a Christmas tree for the next 20 minutes. And I couldn't get over there to turn it off. And you can't tell somebody your password, of course, to have them silence the alerts because it's encrypted. It was just one of those headaches. Also, if we wanted to take a picture, we couldn't necessarily just take one picture with the cell phone and have it go into the electronic medical record for the document and go to the private texting. You'd have to do 2 separate pictures with 2 separate apps because nothing's integrated. It ended up being a lot of extra work.
Because if this thing goes into the camera roll of my iPhone, then we've
technically you're not supposed to do that.
Violated HIPAA. Wow, that's amazing. I think this is an interesting insight into it, because a lot of times we genericize and we think of the electronic things that are happening behind the scenes at a hospital, and we think like EMR, the electronic medical record. But this is outside of that. That's patient data storage.
That's a piece of it.
And reference.
Yeah.
But these are things that need solutions apart from that. And the default would be in my pocket, but I can't always use that the way I would want to.
I mean, EMRs do have mobile phone apps, but they are not always the best for quick communication. And lots of times, like if a patient wanted to get a hold of me, they would be routed through the outpatient messaging system through the electronic medical record, and it would end up with my nurses to start, because that's how everything was configured. If they wanted to get a hold of me specifically, and I wasn't on call, that could be a challenging thing. And sometimes it's a very quick question. Sometimes I'm on vacation and I don't really want to be found, which is another problem because physicians sometimes do need a break.
Yeah.
And there should be somebody perfectly capable of covering that. But if you give a patient your cell phone number so they can call you with a question or a concern, even though that makes things a lot easier in terms of a quick resolution so nobody gets upset or an easy answer, all of a sudden they're calling you while you're on vacation in Hawaii.
Now you're opening yourself up for all sorts of communications that might not be bad, but the time might be
sitting down for
inappropriate.
Thanksgiving dinner, Christmas morning. When I'm not on call, I have gotten calls and texts
all
on
things
all those
you've
times.
experienced.
Unfortunately, I was actually on call, but I kept getting texted during my uncle's funeral.
Oh my goodness.
Yeah, it's just one of those things where there's no way to really gauge, is this an urgent thing? Is it an emergent thing? Can this wait for an hour? We just don't quite have technology that can integrate all of those pieces and make it something that's user-friendly enough for your not necessarily technologically savvy doc to figure out that works like that. We actually had a lot of docs retire when we launched our EMR at the old hospital, actually.
Because such a big change to adopt.
They said, we're not doing it.
You want to get into problem solving, you want to help people, you're helping people, and this whole communication issue of when is the right time to answer this question and which should get my priority.
Yes.
Seems like a simple thing.
It's not.
But it's not a simple thing at all.
No. For instance, we had been chatting earlier about some of these topics. When you have a patient where you prescribe a medication or you tell them how to do a dressing and they get home and they can't remember, or they run out, or something didn't get delivered, do you want that message? Do you want that message now? Do you want that message to go to your office where they can actually maybe handle some of this? Is this something that's emergent enough where you want to tell the patient, yeah, you need to go to the emergency room and get this checked out right now, I'll meet you there? There are a lot of concerns there. And there's also the point we have a question or a patient who says, well, I'm just going to make this up because I don't know how to get in touch with my doctor. You put somebody on anticoagulation for a deep vein thrombosis or deep vein blood clot, you expect them to start it that day. But if you send them with a prescription out to their pharmacy and their pharmacy doesn't have that medication, now the patient doesn't get the medication. And if that's a Friday evening, because these things always happen on Friday afternoon, evenings, that patient may not start that critical life-saving medication until Monday when you might get the message. So we still have a lot that we need to solve in terms of making sure patients get the information or get access to the supplies and the training that they need when the physician or the physician's representative is not available.
I know that a year ago, when we most recently spent a lot of time in the hospital with our son, the scheduling, just the basic scheduling came down to be the biggest part of the headache. It wasn't so much this or that. It was all about can you coordinate these two things, the coordination of care. Well, as you're doing this, let's go back to your day here, because and we had a chat here. We're going to give Kevin some shout outs. See if you've been a judge for us before. You're going to have to reprise that role really quickly. Tom Schultz from one of the best rock groups, Boston, received his master's from MIT.
Fantastic.
And what a cool album cover, says Kevin.
Nice.
So,
Thank you, Kevin.
There you go.
That's awesome.
There you go. Thank you, Kevin. We love it. Let's go back to your day, Niki. So as you're going through, you're trying to coordinate care. There are these basic frustrations of even something as simple as just communication. What are the kinds of conversations that you need to have, both with patients and with your staff, with your colleagues? What are the nature of those? What are the most common types of communication that you're having?
When I'm talking to a patient, usually want to make sure, at least I want to make sure, that they understand their medical concern. I find that if patients aren't engaged and they don't understand what the problem is, they're not going to understand the treatment pathway. So making sure that I'm talking in a language that is understood well at a level, or using metaphors to try to make sure the patient and their family gets it, that is first and foremost. Now that becomes an issue when you have a patient with maybe different language skills, and that could be the fact that I'm fairly good with English most days, but my Arabic and my Spanish, pretty terrible. So is my Urdu. I can't do it. So if they don't have somebody to translate at bedside, I may not be able to explain what's going on or even do a physical examination and patient medical history. In a hospital setting, that's not usually a big deal because you have translator services available at most major medical centers. But for instance, if you have a patient who goes home, do they have somebody who can translate their post-operative instructions for them? There are some technologies that are trying to address this, but we do not have a good universal way of doing this yet. Patients who use sign language, great, and there are some new video groups that are trying to do this, but there's nothing that has really taken hold and has become the standard of care in the market for that. My sign language is also terrible. So, if I'm in a room with a patient, I really need to have somebody there to help me, is to make sure that patient understands what's going on.
That's amazing, and it's something you need at the moment. Otherwise, the communication can't happen. And like you said, a major medical center, maybe you can call somebody up, but even then, you're waiting around for them to get there if it's an urgent sort of thing.
And if you need to get informed consent, that becomes a huge issue, because you don't want to tell a patient, well, you could die, you could have a heart attack, you could have a stroke, you could have to go back to the OR for emergency bleeding, unless you know that this is a rare thing for them and you can convince them this is going to be a small percentage, but we have to talk about it. Patients can get really upset, even if they are, English-speaking, adults. Maybe there's a little dementia, maybe there's a little comprehension issue, and it's challenging to try to get that through to a patient. So sometimes you have to talk to a family member, a caregiver, and they may not be at bedside when you're making rounds. So then you have to try to coordinate with them. And if I'm you can't just call them, because then you're calling on your cell phone, so you have to be someplace where you can use a hospital appropriate line. If you're going to have that patient call you or text you, then again, you're going to have to give out your cell phone number, and that might not be something you want to do all the time. I know I had shared with you, I had a patient who was okay, but he had an issue on a weekend. It was not an urgent issue by any means, but his brother was a physician, and his brother called up the hospital and said, I'm Dr. Smith, I'd like to speak with Dr. Kennedy. And they gave out my personal cell phone number to the patient's family on the premise that he was a physician. And then I'm getting a phone call Saturday afternoon while I'm at PetSmart asking me, what should we do about this? And I thought, well, I'm not even on call right now. This is not really fair. And that's frustrating for docs because, as we know, sometimes you do need that little break. We always have somebody on call, somebody who's covering, somebody who can answer that question. And sometimes, especially if you're having maybe a family crisis of your own, you really need to just take care of that. And you don't want to be disrespectful to patients, to their families, but it's really hard to separate that out.
Yeah, we live in such a world where everything is distributed, and we've got this feeling like anyone should be at access at any time, but we don't realize what a burden that can put.
I think we see that in many different industries, but especially when you're worried about your loved one, their health care, it gives an extra sense of urgency, even if that urgency really isn't quite so urgent.
Yeah,
so.
Yeah, it's a huge. We've experienced that from both sides. So I think that's a very important one. How about your coworkers? How about your colleagues? What kind of communications are you normally having with them? So we said from the patient perspective, it's I might have to communicate something really important to you about your care. I might need to schedule that with you so that I can get to you or your family members or a translator who can come be part of that. And so there's a large scheduling issue there. There's a communications issue. And then you're finally present with them and you have that conversation, which could be a hard emotional conversation to have
Sometimes.
many times. How about your colleagues? What's a typical conversation that you're having with your colleagues?
Well, if it's a resident or like a nurse practitioner or physician's assistant, then I want to know all the details. What's been going on with this patient? Do we have a consent signed? Is the case boarded? What were the lab values? Did that CAT scan get done? Again, not something I can necessarily do. And if that person is rounding with one of my partners or one of the other physicians from another service, I may not be able to just interrupt and figure that out. I have to find a way to get that information on my own. If it's another colleague where maybe we're both trying to coordinate because we're on the care team for that patient, maybe my plastic surgery colleagues or my orthopedic colleagues, I need to work with their schedules. Again, we can't really do a group chat or like a WhatsApp chat because it's not really hospital ordained, so to speak. We can do email through hospital email because that is considered secure, but sometimes email is not the fastest way to communicate, as I think we all see. I'm assuming people still use email these days. But
Maybe
I think
you can define that term for us, but yeah. No, it's very true.
So it can really make the conversation quite slow. And if you have 20 of these conversations happening on your email and 20 people are responding to each of the 20 conversations, your inbox suddenly becomes very, very full, and it's hard to sort out that noise.
This probably depends on a per person and a per hospital basis, but what is protocol? Because I imagine if you're sitting there wrestling with scheduling issues and having to adjust on the fly, which I think a lot of us don't understand how much clinicians have to adjust on the fly in a hospital setting.
Oh, yes.
And you're having to do that. What gets priority? Like, can you expect that your colleagues are going to be available to you at sort of preordained times? Or might they be fluxing too, such
it's
that
all
now
flux.
Everything is flux?
Everything's fluxed up. So it gets challenging. It's really challenging, especially because we haven't talked about this, but you might get called to the OR emergently.
Yes.
You have to drop what you're doing. So all of the patients who are waiting for you now become a second priority, and you have to go take care of whatever's in the OR. And that's just not me as a vascular surgeon. That could be pretty much any specialty. I mean, I've seen emergency orthopedics cases where they've got to go because there's a limb at risk, in which case I'll probably get a phone call later. Plastic surgery, they could have emergency bleeding from one of their flaps, and they've got to rush that patient back. Cardiothoracic, you just imagine the disasters that happen sometimes in emergencies with heart patients. So you're talking about people who have a very limited schedule anyways, and now it's all thrown into chaos.
Wow.
Yes.
The engineer in me, and you would resonate with this, can't help but want to build a system diagram, and maybe half of our audience just went, oh, what on earth are they talking about? But the things that can mess how this day is going up for you, you've got the emergent scheduling things with the patients. You've got the emergent scheduling things with your colleagues' patients that are making it so that you can't get with them when you need to. You've got being able to be pulled in at any moment as a surgeon into the OR for something emergent. Are there any other major variables that throw a given day into chaos?
We have not talked about the biggest problem for surgeons.
Okay.
And that is knowing when your OR case is going to start.
Interesting.
Yes, because you may have it booked at 11 o'clock. That tells me it'll be at least 1:30.
Oh my.
Yeah, well, you just don't know. I mean, you're going to be there ahead of time to have your patient all consented, ready in pre-op. You make sure everything's all set. You mark the correct side. And then they tell you, Dr. Kennedy, there's a delay. Yeah. I know that you're supposed to start in 5 minutes, but it's really going to be an hour from now because the surgeon before you is taking more time. And then we have to turn the room over. Or maybe a piece of equipment broke in that room, and now we have to take care of that. So it got to a point, actually, where even the scrub techs were laughing. They're like, how many hours this time, Dr. Kennedy? I'm like, oh, it's only 2 this time. Last time it was a 3-hour delay.
Wow.
I mean, it got to the point I told my patients, I will only schedule your cases on Thursdays at 7 a.m. And they said, but I don't want to get up that early. And I said, nope, because it's the only time I know I'm going to start on time.
Wow.
So, and it's true. And you can't really predict that easily. It's not something that the electronic medical record can always tell you. Sometimes you have a great OR staff who's going to let you know, but they're busy people. They don't have time to sit there and say, oh, I didn't call Dr. Kennedy and give her the 15-minute warning. They've got other things going on. EMRs do try to figure out dynamically about how long a particular doctor will take for a particular type of case when they're doing their scheduling, because some of these are pretty advanced algorithms.
They try to learn from what's happened before.
Yeah, but it's still variable, actually. So my very good friend, who is not a physician, has never worked in the OR, and it's just, she's wonderful, but she was a little naive on how this works. She said, all right, we need to go talk to this doctor about a quality, he needs to fill out a document or something. Let's meet him when he's done with his case at 11:38. And I said, how do you know he's going to be done at 11:38 a.m.? And she said, well, that's what it says in the computer. His case is going to be done at 11:38. And I said, you know, that's just what the computer says. He's not actually going to be done at 11:38. And she just stopped and thought about that for a minute, and it really hadn't dawned on her. And she's a very experienced hospital administrator, but it hadn't really occurred to her, because she'd never worked in an OR, that those are artificial times come up with by a computer algorithm that don't necessarily mean that's how your day is flowing.
They don't represent reality. They're doing their best to you, but it's always lagging that reality.
Yeah.
That's interesting. I want to dive in, and this is not something we talked about before, so I hope I don't go too far off the rails here, but this whole topic of like, okay, we need the input of clinicians. We need the input of clinicians as we're doing things like designing devices, making startups, talking with the FDA. What you just said was really interesting, because in the world of development, right, one of the things we worry about is biocompatibility. Let's take that for example. And one of the things we think about is how long a device is dwelling in a patient or on a patient or with a patient. And we in our naivete say, well, the surgery only takes 5 minutes. So therefore we can go with the lowest level of biocomp analysis necessary. What you just said, though, opened my eyes up to the fact that there's probably devices sitting on a patient while they're sitting around waiting for a surgery to happen.
Oh, yes.
And this is the kind of nuances that we're trying to dig into, and I think to show need to get unpacked, because the actual use case might be different than I think it is just sitting there imagining this idealized surgical suite in my mind.
Yeah, probably your worst case scenario, you have a critically ill patient who requires some sort of monitoring, either, we'll say an external but sitting in contact with the patient, or an indwelling device, and you plan on taking them back to the OR to take care of this, and you can't take them. Either the OR is not available at that time, or they are not stable to go, and sometimes it can be days before you can get them back in. How do you manage that in a non-OR setting? ICUs are great. I've had to do all kinds of huge abdominal wound vac changes in an ICU as opposed to in a sterile OR environment, and you find ways to do it safely. But it's a lot of effort. It's a lot of effort. What happens when the sternal wound dehisces on that fresh open heart patient in the ICU, and you have to get it back together? You have to make sure a lot of pieces are falling into place to make that happen, and it may not happen on a dime. So
it's kind of amazing when you think about it, because the use case that you think you understand, you may not understand. You got to get to this level to be able to say, oh, we understand how this could go sideways. I think it's really fascinating. So we've got communication with patients, we've got communication with your staff, we've got this issue of do I even know, like it says on the calendar that it's going to happen at this time, but
just resource coordination.
Resource coordination as well. We do have a question here from Richard. How do scheduling issues between medical professionals involve other issues with new medical devices? I think this is maybe an inversion almost of kind of the question we were just looking at. An example is these devices are being tested out with patients as part of a study on the effectiveness of the device. What challenges to this do you see? So I think what maybe you understood the question better than I did. I think what Richard is asking is, we've got a new device out there, or maybe even any existing device, and you've got an issue where that device causes something else that then cascades back. How do you perceive that inter-device issues, as well as, hey, here's a new device, but it changed how I did things, and now I'm in trouble in some way, shape, or form?
Sure. If I understand the question correctly, if one, we'll say, orthopedic device causes a problem that would require the intervention of a vascular, a plastic surgeon, or a general surgeon, that can certainly make a difference. And I think if there's an orthopedic patient, and here's my example, they said, all right, we have a person with a terrible fracture, and the orthopedics team is taking them to the OR right now to reset the bone. By the way, we think the blood vessel is severed, so Dr. Kennedy, you need to come and fix it. Okay, well, I have another patient on the table in my vein center, and I've got a bunch of other things I'm doing today too that I have to do. My own case is scheduled. Now I have to drop what I'm doing because the orthopedic doctor decided, oh, I'm going to fix this bone, when perhaps that patient should have been transferred to a higher level care center where they've got lots of resources and all of these people not sitting around, but you can certainly have people from all these different services available more readily.
Yep.
But if they had kind of thought about that in advance, then we could have gotten that patient transferred where it could have been a little more one-stop shopping. So in the same way with the device, I think you have to make sure that you plan for all of those little things, even if you don't think they're going to happen. You know, talked to an aortic device rep, and I said, well, what happens when your device leaks? And he said, well, our device doesn't leak. And I said, they all leak. I mean, eventually they're all going to leak if they're in there long enough. So what's your backup plan? You have to think of these things. Even if you think they're never going to happen, life finds a way, to quote Jeff Goldblum, every time. And they will find some way to go wrong. You just have to be ready for it. So I think that communication and anticipation makes a big difference. So if there's a new orthopedic surgery device, why not ask somebody from plastic surgery or from vascular surgery what they think about it?
Yeah, that's a great point. And Rich, if there's more to a question than that, feel free to raise your hand and we can try to bring you live here. We'll look for your hand up in Zoom if you want to ask more than that. But thank you for that answer, Dr. Kennedy. The question actually motivates me to think clinicians are so used to dealing with such crazy situations that I think, is it true that oftentimes if a device fails or does something a little nonlinear, you're actually kind of used to that?
Yes. We love using wound vac devices for clean wounds. Of course, they really help with healing. So we also know that different companies make different types of wound vac devices, and keeping things very, very generic, we know that some work a little bit better than others. Some of that is a technical, some of that is an application, and we know that wound vacs applied in the hospitals always work better than wound vacs applied for a patient at home. And again, it could be just, you know, user ability to put it on correctly. Sometimes it has to do with the sponge or the tubing, but we know that in the hospital it's going to go a little bit more smoothly. So we expect it to fail at home, and we figured, well, we're just going to bring you back to our clinic a little bit more frequently because we know this isn't going to work for long. Let's see how long we can get before we know it fails and we have to switch to something else.
Yeah, you guys are used to things adapting on the fly.
We call it pivoting.
Pivoting.
We call it pivoting.
That's fun. They call it in startups too, right?
There we go.
So there we go. Well, this is great. So let's dive a little bit deeper into this day here. And I just want to mention to our audience, this is great stuff. We're going to keep going a little bit here, just a little bit past the top of the hour. So I do want to say, if you have any questions you want to get to Dr. Kennedy, feel free to bring them up here before the top of the hour. The official show will close at 3. We'll probably go a little bit into overtime because we've got such great stuff here that we want
so much fun
to dive into. Yeah, and it's just so good to see Dr. Kennedy in person here. So it's amazing. But we were talking a little bit about some of the things that get delayed. One of the things you mentioned to me earlier was delays in care. We talked about some of the communication reasons, but you mentioned things like delayed labs, inability to undergo imaging. We talked about the OR, just knowing when you're going to get into it, but maybe even go back into that. Other things you mentioned were patient transportation. What kinds of things then do you have these downstream issues with? Where does care coordination sort of fall down, and where are we waiting on things?
Well, I'm just going to throw a shout out to the case managers who work in hospitals, because those men and women have a very challenging job.
Yeah.
I have worked with them in many different hospitals in many different settings, and unfortunately it's kind of the same problem. There's a lack of, we'll say, portability. Sometimes you'll have a different website for each of the rehab centers or each of the different insurance companies. I mean, they're trying to get things arranged for that patient to be discharged. They have to physically print out all of the relevant clinical documentation, scan it in, and email it or fax it up into each individual portal. So if your person is trying to get into one of 10 different rehabs, depending on who has a bed that's available first, they may have to do all this for 10 different website portals. That makes it very challenging for them. It's a huge waste of time for them, too. Sometimes we can't send things electronically. There are some limitations on electronic prescriptions. We aren't able to see if a pharmacy has, or more likely a durable medical equipment store like a Binson's or Wright and Philippus that has crutches, hospital beds, those sorts of things. What they have, when they can deliver it.
Oh, wow.
May not be able to send a patient home. I actually had a patient where we could not get the wound vac delivered, so that patient stayed like an extra day or day and a half, increasing their length of stay and increasing the hospital bed, that was taken up by that.
This is an incredibly costly thing to stick around, all because you can't find out or know for sure that what they need when they get home is going to be there.
Also, there are some limitations with some of the different rehab centers that patients can go to. It's very difficult to find a rehab center that will help a patient who's on hemodialysis, or if somebody is on a ventilator, or God forbid, both, because having a patient who's vented and done dialysis, there are very few beds available for those patients. So they may stay in your hospital ward for an extra week or so, waiting for bed availability.
Wow.
Yeah, and a lot of it is because they're very technically demanding pieces of equipment that required trained personnel. We just don't have an easy way to do dialysis on a patient in a rehab center. So.
Wow, it's incredible. And I mean, we've had experiences like that in our own family where it's like you're waiting there, you're waiting, and the thing you're waiting on becomes frustrating. And at that point, it's frustrating for everybody because just one little thing, if it could be cleared up.
And when you have your conversation with our friend, the hospital administrator, I'm sure he'll have quite a few things to say about turnover rates in the hospital beds.
Yes, I'm glad we can give the hospital administrators a voice because, like you said, they make the whole thing run, and I'm sure they're get a lot lot of abuse as a part of the process.
They're pretty underappreciated in many cases.
Yeah, that's good. We get to celebrate a little bit. So some of these things, let's see, that we talked about before. We've talked about care coordination. I know you said you were going to talk mostly today about inpatient things. Is there anything that you want to talk about outpatient?
I think my colleagues will probably dive into that quite a bit, and I think there's a lot of overlap. The one thing I will say is I helped to run the wound care system. We actually started it at our hospital. Dr. Hassan, who you will be chatting with soon, and I were two of the main drivers with that. And taking care of wound care patients, you have a lot of very specialized items. Some are covered by insurance, some are not. Some need to be delivered to the house. Some need special team members to come, which means you have to make the arrangements for them to be available and apply those dressings. Sometimes you need to train family members on that. Huge amount of education as well as actual resources that go into a patient population like that. This is a vulnerable patient population anyways. Most patients who have wounds for a reason. Getting good quality care is a challenge for them. So trying to keep all these moving parts so that they can get what they need when they need it without having something extra or more than they can afford, that's a puzzle unto itself.
Wow. So. Yeah. You're dealing with so many moving parts. I guess sort of two questions that pop into my mind. And one of the things that we're doing here, right, is to open this conversation of there's so many places where getting to hear this kind of a voice is so important. Because if you're out there thinking about how am I going to help somebody deliver care through a device, through a product, through a service, through your own healthcare system, to hear the voice of the clinician is really important, because I think what you guys deal with on a daily basis is so underappreciated. People just don't know. They only know that when you walk into the room and have that conversation with them, that's all they see, and they don't see all the stuff behind the scenes. But then that allows us to sort of ask different questions about the process. And like I mentioned earlier, I know when we go to FDA, one of the big things is the discussion of risk. And FDA, they do their best to analyze devices that are, here's one over here and there's one over here, and they're all different, and they're getting all these new things shoved down their throat. And oftentimes, in good faith, they will say, well, we're worried about this risk. And we'll look at them and we'll go, we think you're overthinking this. We think you're being a little bit scrupulous about this point.
Sure.
And of course, how do you determine that? Well, you go to clinicians and you say, what's your lived experience? Are you really worried about this, or are you not worried about this? And often relative risk will carry the day. So here's a question for him, sort of putting you on the spot here. But in terms of relative risks that we don't appreciate to patients, what would you call out? Because this whole coordination of care thing you mentioned, like we could need something on Friday and we're not going to get it to Monday, and the patient's going to suffer something tangible during that period. Are there any other risks that you can think of to patients that patients routinely, by circumstances, end up getting exposed to that are not understood or not appreciated and should be taken into account more widely?
That's a great question, Gene. I think if I'm going along with where you're saying, the biggest relative risk for patients is them not realizing that there's risk. So they don't ask the question, or they don't think to get that feedback. So when you have a patient and you think that they're doing okay, you send them out, and even if all these other things are happening or not happening behind the scenes, when the patient or the patient's family comes to you and says, well, I didn't know that this was an issue, I didn't realize this would be a problem, that adds a whole other layer in there. Because if you can get that information to me, you can tell me about that problem, I can look at it and say, oh, this will wait for till the morning, or no, you better get to the emergency room, or hey, I'm going to triage this out. But if you don't know, it can hurt you in this case. I think that there are some things that you said the FDA worries about where they're thinking of every possible use case. And I know we were chatting a little bit. I was chatting with a startup just this past week, and they had a very interesting device in the vascular space. And they say, Dr. Kennedy, do you think there would be any harm if we used this device in a patient with a deep vein blood clot? And I said, well, I probably wouldn't use this device, because I would put the patient on an anticoagulation medication, a blood thinner, because that's the standard of care. And I'm not quite sure if that was something that had quite occurred to them, because they were thinking of, rightly so, every possible risk that could happen. But from a clinician standpoint, I said, well, I'm probably going to put them on one of the anticoagulation medications, so I don't think it'll make a difference, because this is probably not the right market space that you should be worried about in this case. So having that clinical input hopefully will help them to direct their resources to something a little bit more meaningful, I hope.
Well, it's really interesting, because as we've done these different series and we talk with investors and we talk, and we talk with our clients as designers and others, the answer that you always get back is, here are some general principles, but let's look at your specific situation, because the answer that you get might have a lot to do with what you're specifically trying to do. You just mentioned a case where great device, great idea, I bet the technology works, but the problem wouldn't actually exist at that point in the clinic when the device was being proposed to be used.
Probably not.
Probably not.
I mean, possible,
Yep.
but it certainly would not be a routine question that you could easily just say, little disclaimer, do not use in case of this.
Yep.
And you're done.
But if you're talking about building a device, you're talking about building a company, you're talking about getting investment and getting engineers to work on it, the engineer's not going to tell you that clinically this would no longer be presenting in this way. The investors probably aren't going to be telling you that. Your manufacturer's not going to be telling you that.
Yeah.
We need that clinical input.
Yeah. I mean, I would hate to see a young startup spend lots of time and money and effort going down a research pathway to test something out when it may not be clinically applicable.
Yeah.
Yeah.
Yeah, that's really amazing. I'm going to pause for about 30 seconds here. We'll pause and see if there's any other questions from our audience. You guys have been great today. We appreciate your input, and we did just learn something about Tom Schultz from Kevin. So thank you for that, as well as a question from Richard. So we'll pause here for just a second to see if there's any other questions. I want to thank Dr. Kennedy for her time today. Before we're going to continue for probably just another 5 minutes here, because we do have one more question about electronic medical records, which we're going to get to. Everyone loves those electronic medical records. But if you have to leave us at the top of the hour here at 3 o'clock, we're thankful that you could be with us, and we're looking forward to continuing this series next week with another of Dr. Kennedy's ArborHive colleagues. But as we come here to the top of the hour, let's tackle that last question.
Oh.
which maybe takes us another hour to do. But we're going to talk about electronic medical records because documentation in so many industries is important. And of course,
it's huge.
You know, you're running in and out of a patient, and all you really know is what you can reread there in the record or what you remember, which hopefully you're checking that against the record as well. And I think people think that at this point in history, I ought to be able to shove that information around like nobody's business. After all, I mean, the bank can, you know, I can be anywhere in the country and I can get to my bank account and find out what is happening. I should, you know, the doctor across town ought to be able to know exactly what's going on as well as this doctor over here. I don't know, but that's not actually how EMRs work for the most part.
So I am a senior member of IEEE, and I love the fact that we have IEEE standards. I know the American Society of Mechanical Engineers, also a lot of standards out there. We don't have that for medical documentation. Wow. It is just not there yet. They're talking about it. They're hopefully working towards it, but we have not seen it yet. There are several different large healthcare EMR companies. Epic is one, Cerner is another, Athena Health is a big web-based one. There are a handful of others, of course, as well, but just throwing out those three because you hear about them a lot. Many of the healthcare systems in our own area use Epic as their electronic medical record system. But just because I'm using it at my hospital does not mean that my colleague who's at a competing health system that also uses Epic can see all of my notes. They certainly won't be able to see any of the images I took. All they could see would maybe be the report that I had used to describe what I saw during that case. But not everything is readily available. It's usually not integrated into the actual system that I have. So if I wanted to see what was happening at the University of Michigan's healthcare system, I would have to leave my hospital's thing, go through a little back door that they have and get into their medical records and then dig through everything, which might have different labels than what I'm used to. Yep. Like I might call it a vascular surgery visit, and they might call it just a generic clinic visit. I mean, sometimes the labeling is not synchronous.
Does that create issues for like billing and other things like that where things...
Oh, they always get the billing right.
Somehow I don't believe you.
Yeah, no. No, I would say that somehow our accountants always manage to figure that out. They don't need the doctors to help them with that piece. They've got the billing.
They've got the billing figured out.
Oh yes, but from a clinical documentation piece, things can get lost along the way very easily. And if you want to go from Epic to Cerner or from Athena to Epic, it gets very complicated. I mean, when it comes to actually trying to get a hold of a patient's CAT scan, I would just tell them, please go to the place you got it done at, get it on a disc, drop it off at my office, and we will get it uploaded into our system. And that was really the best way to do it.
Just to brute force it at that point, to make a direct line between what you need and
even if it would show up, it would be weeks later. And there's a good chance whoever's in medical records may not know what that disc is, or that needs to be flagged to my attention. This is now uploaded. That would never happen. So
I think one of the things that people might look at that and they might say, oh, well, that's terrible. That's a failure of the software. But of course, a device, including software, can only do what you pre-specify you want it to be able to do, and cross healthcare system compatibility is probably not something that is top of mind when you're trying to get your own system to work.
I mean, you have your external electronic data warehouse, but not everyone accesses that well. And one thing that I've come across with many startups is they try to work within the framework of a major EMR, but there's a lot of proprietary boundaries with that, and sometimes it's very challenging for them to get in there and get their software app to be used. If they stay external to the EMR, they avoid a lot of those problems, but then they have to worry about HIPAA and cybersecurity, which is not a small thing. And more importantly, docs are already looking at the EMR, or nurses or respiratory therapists or anyone. They're staring at that EMR all day because that's the constant flow of information for that patient. They may not want to look in another dashboard or another app or go to that other website to try to call that account up. So you have a lot of bells and whistles coming at your clinicians all day long. And if you're saying, oh, I don't need the EMR, I'm going to design this great software platform, you have to assume that somebody's going to look at it and somebody's going to know what it means, and they're going to have some staff member available to make that extra phone call or send that extra email saying, hey, you have a red flag that just popped up, you need to come on in and be seen by the doctor, because they don't always have staff who's just going to sit around and check that dashboard and make those phone calls.
Yeah, these things are they're sort of balanced on the head of a pin just a little bit.
A lot of it is just resource management. It'd be nice if we could automate some of this effectively enough. And I think that they are trying to do some more AI, more predictive and prescriptive analytics with this. One of our other ArborHive docs will hopefully talk a little bit more about that. But it remains a challenge. There's a lot of work that still needs to be done in that SaaS field.
Yeah, it's a huge area. A lot of cool things can happen, but
so much
work to be done.
Yeah.
We got a question here from Rick. Can you talk more about how a company engages with ArborHive? I think that's a wonderful question. Tell us more about that. We're going to put some contact information up on the screen here once you tell us.
Absolutely, absolutely. So what ArborHive does is we like to get clinicians involved with the actual company. So if you are just looking to meet a clinician and say, I just want to do some customer discovery interviews, do you have half an hour of time? Reach on out to us. We can find a doc, hopefully, not in every specialty, but at least in several specialties that could maybe give you that feedback that you're looking for so that it helps your design process. Some of our docs have gone on to become advisory board members or like medical advisors, directors. It's a really very dynamic relationship, and we love engaging with startups. As I said at the beginning, if we don't have startups and developers who have interesting problems for us to think about, there's not much for the docs to do. So please reach out to us and let's see if we can try to connect and hopefully get you engaged with some docs.
And what is the best way to reach out to ArborHive? We've got the website, arborhive.com, that we'll put up here on the screen in just a second. Are there any other contact points that we should be aware of?
It's really complicated. You just have to email arborhive@gmail.com.
Arborhive@gmail.com. We'll have that up here on the screen in just a minute. I'm sorry we didn't have that up previously, but we'll bring that up here.
If you go to the website, we actually have a contact portal there. You can always just send us a message there as well.
That's great. Contact portal up there, and we have it up here after some amazing editing here live.
Fantastic.
I'm glad that was after the hour break, since no one will see that on reruns, except that most of our audience has actually stayed. Thank you all for hanging on. We only lost a couple, so appreciate that. There it is, arborhive.com, arborhive@gmail.com. Great question, Rick. Yeah, and I think just over time, I am realizing for every one of the disciplines that we interact with in this ecosystem, how important it is to have that conversation. Like you said, you may not even know why you're having that conversation. We heard this from a lot of our investors in the early stage investing ones. We're happy to have that conversation. We're happy to talk with you. You may be surprised at what comes out for your early stage investing, for your clinical strategy. All of these things require having had that conversation up front. So I think this is going to be really fun over the next few weeks.
I hope so. ArborHive docs love innovation, and they like to engage. Sometimes people are a little put off. They say, oh, the doctor is really busy. I don't want to bother them, or I would never be able to afford that doctor's time. But ArborHive docs do this because we love this, and we like to think that we can make ourselves pretty accessible, knowing that startups are truly starting up in many cases. We're happy to figure something out, just so that we have the chance to engage. Docs love the opportunity. I mean, we sometimes like to do things besides see patients, and this is a great chance for us to get creative that we don't necessarily get a chance to do in the clinical world. So yeah, absolutely. Have people reach out to us.
Well, it's a great point too, because what you're doing is you're not just taking like retired docs who have nothing better to do. You're taking docs who are actually they have jobs, they have careers.
Oh, yes. Most
they're
are still
well
practicing.
connected, and they want some additional exposure, and you're finding those matches. So I think that's just really cool. And I'll say every time I've reached out to you, Niki, it's like, hey, do you know anybody who does this kind of thing? We need someone to talk to FDA about this. Boom.
Yeah, and I will say we are not an investment organization. There are specific groups that are looking for docs who, basically they're going to charge a membership fee for the docs, and they may or may not get some value out of that, or they're expecting docs to invest, and that's really not what we do. If you're a startup looking for financing, we might not be the group that you want to talk to first. Some of our docs are into that, but really we're interested in engaging with startups about the technology, about their planning, about their developing their use case. So.
This is amazing. I'm looking forward to the next,
So much fun.
well, we're going to say the next 2 weeks, and then we're going to have a week off for the Women Who Innovate series
That's so
along with
fantastic.
MEDC. We're looking forward to that. I will be seeing you at MGCS
Yes.
in just a little
We get
while.
to do this
we get to
again.
do this virtually again. And yeah, Nikki, thank you so much for putting this all together
Thank
and
you
for
for
being
having
here
us.
today. We'll just look forward to the rest. Thank you for being here today, and for so many of you for sticking around to hear the end of this conversation. We'll look forward to next week here on MedTech Crossroads. Thanks so much for being with us.